Good morning and welcome, everyone. This is our July Project Echo meeting. We're welcoming people as they trickle in at the 10:30 hour, as we do on the third Wednesday of each month for our Project Echo sessions. I'll mention as we gather that I know many of us have been affected by weather of late. I'm thinking of my Houstonian friends having experienced Hurricane Beryl. Although here we are a week and a half after that, I actually have some friends who are the 6 houses on the block still without power, hoping to receive it by Friday of this week. So our thoughts are with you as you recover. Same I'll mention for our colleague, Dr. Kathy Bishop in the great state of New York. She and I were actually on a Zoom meeting together yesterday when we were cut off. Only later did I learn it was due to a tornado that blew through her New York State home. So we think of her and the city in their state of emergency as well. Anyway, thank you to you 5 who are with us. This month, I'll give you an idea of what we are looking forward to over the next hour and a half. First is a primer to many of you. I know you're familiar with the Project Echo model, but to those who are not, it's an all teach, all learn. And that pithy statement basically means rather than a regular webinar where the presenter talks to you with no return information for the whole duration, we're kind of doing a hybrid. We'll start the first 30 minutes or so with what we call a didactic lesson. This month, we'll be hearing from Dr. Seth Keller, a neurologist on our hub expert team, who will be talking about seizure disorders in adults who have intellectual and developmental disabilities. And then for our case study presentation, we'll hear from Dr. Kathy Bishop. And this is the part where she'll present information anonymized about someone who is an adult with IDD, but has need of our advice and collective knowledge to help improve, usually because of a recent change in health status or living situation. And that's when we encourage you as an audience to type in or voice your questions and contributions. So we thank you for joining us. Catherine, do you have any announcements you'd like to share before I introduce and turn it over to Seth Keller?
Let's see. I think the biggest one would probably be that we are going to have an advanced topic series coming up. And if you are attending the Echo, you are in our email database, and you will be getting information about that probably by the end of the day today. And we encourage you to join us for that. And I think that's the big one I think of right off the top of my head.
Thank you. I can say I'm looking forward to that series as well. I'm a lifelong learner. I look forward to learning from others.
And also one of our presenters on the series.
That's true, and I'm looking forward to presenting. So thank you for the invite. As promised, I want to turn over our microphone to Dr. Seth Keller, who's a past president of the AADMD, that's Developmental Medicine and Dentistry, as well as the co-president of the National Task Group on Intellectual Disabilities and Dementia Practices. So, Seth, we're looking forward to learning from you about seizures in adults with IDD. Thank you.
Thank you very much, Cameron. Do you guys hear me?
We do.
Very good. I can talk all day long about this topical area. So it's a very expansive discussion on any issues related to seizures in the developmental population. But in the interest of time and trying to focus on this and be able to get to our case discussion, which will be really great to hear, I wanted to dive into this. And as a background, and Cameron, thank you very much for the general information about me, is I'm a neurologist, as stated, and I've been practicing neurology for, God knows, 30 years. I've been doing this for a long time. And as a neurologist who treats adults, not just those with developmental disabilities, but anybody who has a neurologic complication. So seizures are one of the probably the biggest thing that I see on a regular basis in my daily work practice. But in particular, those with intellectual and developmental disabilities is a major health complication. And I'm going to kind of get into some of the generalities of it. First of all, what I thought I would do, at least on my first slide, is really just give a general overview of what this topical is about, like what seizures are. So this is really just a slide that talks how we as neurologists, we as physicians, think about how we classify them and how we call them. And what a seizure is really the best way to think about it is a short circuit of the brain. And what you're seeing in the bottom, that red squiggly thing that's passing in front of you, that's actually what a seizure looks like on a brainwave EEG. So literally when the wires are plastered on someone's head and we're measuring brain activity, those pointy looking things that you see that are episodic, that are going down, that's actually what a seizure looks like on an EEG. But what does it look like to the observer, to the person that's experiencing it, and to the person who's watching it, the caregiver, the family members, etc.? Is there different kinds? And this is really what the slide is meant for. And there's really a categorization of seizures, and it's really relatively three different varieties. One is called focal onset, and that's where to the far left. And focal onset, you might be able to see it in the green with a little star around it. Focal onset means that the seizure, the short circuit, is coming from a small specific area. And the word focal means small specific area. That's what that means. And when people have that, that's what the EEG would show. And that EEG with the brainwave activity would show the seizure activity is coming from that one small spot. But physically, what someone may feel or what it may look like is different. And there's a few different kinds of focal seizures. One is where the person feeling it would be able to describe it. I'm feeling something come over me. I'm feeling something unusual. I'm feeling half my body going numb. I'm feeling something like that. And if you're feeling it and you're aware, that's called a simple focal seizure. But if the person is kind of out of sorts and confused, we call that a complex focal seizure. So focal seizures is small location. It could either be with your mentally sharp, but if you're not and you're confused, that's called a complex partial seizure. The other kind of seizure is the one in the middle called a generalized seizure. Generalized is where the EEG shows that all at once the whole entire brain is having a electrical short circuit, not just a small area like focal, but the whole entire brain. That's what the EEG refers to. And then the way it may appear to the person or those that are observing it, there's all different kinds of generalized seizures. One that people hear a lot about is the traditional called a grand mal seizure. Many of you in the field and who've known about seizures and different people may have heard of a grand mal seizure. The word grand mal is not used anymore. It's now called a generalized tonic-clonic seizure. And tonic-clonic, that word tonic, the word tonic means that the person experiencing it, the arms and legs are stiffened out. That means tonic. Clonic means that there's a jerking of the extremities. So typically a generalized tonic-clonic seizure means they stiffen out, they have a jerking of their extremities, and always they're having alteration of consciousness, always. No one with a generalized seizure ever can really be aware. They're really out of it, they're unconscious. So the generalized tonic-clonic seizure is the traditional one, but there are other kinds. One of them that I'm going to talk about in a little bit in a few slides is called a myoclonic seizure that we see in Down syndrome and Alzheimer's. And another one is where the whole body can limp to the ground, and that's called atonic. That means like a drop attack. And the other category, the third one, is we don't know what it is. So basically it's a question mark. So those are the general categorization of seizures. And in the developmental population, seizures are very common. And you're also, and I'm going to go back and forth probably using the word seizures and epilepsy. The difference really between the word seizure really represents a single isolated event. Epilepsy, the word epilepsy is someone that has the propensity to have multiple seizures over their lifetime. So you can say they're an epileptic. The other word for epileptic is they have a seizure disorder. So I don't want to be too confusing with the terminology, but I just want to kind of at least differentiate it. In the developmental population, it's probably at least 3% of most people intellectual developmental disabilities. I mean, in the general population has epilepsy in the general population, but in the developmental population, it's probably a like double or triple or even quarter of most people. It's a very common medical complication in the developmental population that has epilepsy. And the worst, the ones that actually have it worse for seizures in developmental population, those that actually have a lesser IQ and also that have more motor dysfunction, like somebody with cerebral palsy. And it's all related to the degree of severity of brain dysfunction. So it's someone that has more brain dysfunction. They have more risk of getting seizures. Those have less brain dysfunction, because seizures are a condition of the brain. In a developmental population, I'll be speaking about this in more detail, there's something called drug resistance, meaning that the drugs we use for seizures don't work as well. That's what the drug resistance word means. And also, I'm going to use the term SUDEP. Sudden unexplained death in epilepsy is a rare but not terribly impossible condition where people just drop dead. That's what SUDEP is, from seizures. And then I'm going to describe in a slide or so issue related to aging and those with Down syndrome and Alzheimer's disease. I'm going to talk about that. In seizures, by and large, this is a slide that really talks about at what point as someone's life are they at a chance of getting a seizure. And this shows across the lifespan of just everybody is that it happens mainly when people are born. You get them early on as like infants and children. It drops off throughout the lifespan, but then it ticks up after age 50. As you can see on the slide, from age 50 all the way to 80, it goes up and up and up and up and up and up. So for me, in my general neurology practice, I see many, 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 many people that either have had seizures their whole life from young, or they start having them anew when they're older. And this will be very relevant when we talk about Alzheimer's and Down syndrome. This slide specifically talks about Alzheimer's and epilepsy. And it's kind of a busy slide, but the take-home message is it really talks about the prevalence. I'm going to be focusing on, if you can see my little arrow here, it really talks about the prevalence of seizures or epilepsy in just general those with Alzheimer's disease. It's anywhere from like 1.5 to 12% in the general normotypical Alzheimer's population. The 80/80 is also dominant, where it's definitely higher than your typical sporadic. But in those in particular that have Down syndrome, it's very high. The risk of seizures and myoclonic, and I'll describe that in more detail, myoclonic seizure in particular, extremely prevalent in those with Down syndrome, Alzheimer's disease, which is DSAD, very common. So even though Alzheimer's disease is prevalent in Down syndrome, and we think of them somewhat, oh, it's Alzheimer's. There are differences between Alzheimer's seizures and Alzheimer's in general of those with Down syndrome in some respect, physically and otherwise, than those that do not have Down syndrome. So there are some differences. And I can go into some of the other nuances of what EEG shows and the progression, but I think this is kind of really, I'll wait till I'll describe more to my neurology colleague. I think this kind of put you to sleep a little bit, but I'm going to go into some of the other practical issues related to it. So when seizures happen, and this is a slide that really was related to a study that came back a few years ago, specifically related to seizures, epilepsy, and Down syndrome with Alzheimer's disease, it really talked about this algorithm. And the algorithm is an action plan. What does the neurologist, what does the physician do? And the first thing is, if the person with Down syndrome had never really had a seizure, first of all, at least from a clinical standpoint, that's very highly suspicious that something new in the brain is going on, in particular Alzheimer's disease. So that's a huge warning sign. And the other kind of it is what kind of seizure it is. I already mentioned generalized tonic-clonic seizure, the old grand mal, but it's also what is called myoclonic seizure, which is really important to appreciate what that is. And what the word myoclonic means is a rapid, quick jerk. So all of a sudden, if you're just sitting there, and you can even mimic it yourself, and I could probably throw my arms out and show you, it's almost if I had my arm up, you can see if I just jerk like that. or if my head moves or my body, it's like a startle. If you can imagine like a startle response, that's it. That's actually what myoclonic means. And there are myoclonic episodes that are actually not abnormal. And there's actually a myoclonic episode that many of you may have experienced yourself. It's called a sleep start. And what a sleep start is if you're actually in a drowsy state and you're like almost like drowsy and you're ready to fall asleep, all of a sudden you kind of get this quick jerk. Maybe just me, I get it occasionally. That is a form of myoclonus. So if you know what I'm talking about, or if you felt it yourself, you're not epileptic. That's actually normal. But these episodes, these myoclonic jerks associated with Down syndrome and Alzheimer's, that's a real seizure. That's epilepsy. So it's not just a movement disorder. And though this algorithm just generally talked about what brings on the seizure, what age does it happen, and then what's the action plan. And it's all related to the pills and treatments that we provide. And one of the common medications that we provide is commonly we use a medication called Keppra or levetiracetam, or another one called Depakote or valproic acid. So these are different drugs, and I'm on our Facebook group where we get a lot of parents and caregivers that are talking about seizures in their loved one, and they talk about what this doctor does and what this doctor does and how they treat them. And this is just some general rules of how these seizures are treated. But the goal of the treatment is to stop the seizures from ever happening, but also try to reduce the risk of side effects. The complications in those with seizures and epilepsy, in particular with IDD, is not just the seizures themselves. There's also a lot of comorbidities that we certainly have in the developmental population, behavioral complications, mood dysfunction, like the depression, anxiety, medical problems, lung problems, pulmonary difficulties, and aspiration in particular, especially what happens with seizures. When someone's having a seizure, they either may not breathe as well, they may not swallow as well, and that aspiration is a common complication with a seizure itself, but also injuries. Injuries are also common practice when someone's having a seizure and they fall. In myoclonic seizure or a generalized tonic-clonic seizure, they can all of a sudden lose their whole tone of their body and hit their head or break a bone when they fall. Not simple. Gastrointestinal problems are also very common in developmental population, but also associated with seizures, but also with the medications, the side effect from medications, drooling, motor dysfunction, constipation problems can be very problematic along the way, bone difficulties like osteoporosis and vitamin deficiencies. So there are different problems can be associated with it. Having seizures, recurrent seizures, means they keep happening is not a good thing. And I already mentioned injuries and falls. They can bite their tongue, and that could be a horrible kind of thing. Toxicity is really related to the seizure medication themselves. Impact on the quality of life when someone's still having seizures, either the seizures or the medication. Then I already mentioned SUDEP, and SUDEP, again, sudden unexplained death in epilepsy, is a rare complication, but it's seen in people that have seizures, but are those in particular that seem to be not under the greatest control. Status epilepticus is a situation in which a seizure itself just doesn't stop. The seizures in most people only last for a second or a minute or two normally. But if a seizure goes on not only a minute, 2 minutes, 3 minutes, 5 minutes, 10 minutes, or longer, that's called status epilepticus, and that's deemed to be a medical emergency. Is what will happen is a person will stop breathing, their heart will stop, the electrolytes in the body will get really in a bad shape, and people can die from status. That's the word we use, it called status. And that's really where it becomes like a medical emergency. And I'm gonna have a slide that's talking about like how we treat these things. A cluster of a seizure is basically where they happen not prolonged for like minutes for all long time. A cluster is back to back. Someone would have a seizure for a second or so, a minute or so, and then they're good for a little bit, and then a short time later they're fine, but then they have another seizure. They're good for a little while, and then they have another seizure. That's called a cluster. So it occurs in a group, which is why it's called a cluster. Psychosocially, the stigma, there's really a stigma toward people that have epilepsy. People feel differently about them, that they're just not normal people. There's something wrong with them. We got to be worried about who they really are. We think of them as being vulnerable people, and they're sensitive, and there's something wrong with them. So there's a whole stigmatization of being having epilepsy, and then if you add a developmental disability on top of epilepsy, you're getting a double-edged screw around, I think, in that respect. There's definitely quality life issues related to that, and you're feeling compromised in how much your life is able to function. People's self-esteem could be lowered because of that, and definitely having emotional difficulties, whether it's depression, anxiety, ADHD, or other learning problems, are very problematic. Adverse effects of medication is very detrimental and problematic and common. And in the developmental population, it's really related to how do we know if you're having a side effect? And I think I have a slide on that. And then the stress to the caregiver, they themselves are kind of caring for the person. What is it to them? In our treatment for seizures, and this is kind of what I do on a regular basis, is how do I treat them? And the most common treatment is drugs. So drugs are the common treatment that we use, and anti-seizure medication, which I have a slide on. But there are, and the way this slide is used is all these circles combining each other. So it's not like one single treatment. There are other additional treatments that we may use together. So it may be drugs, plus they may have had surgery to take out the seizure area that's problematic. They might be on dietary measures called the ketogenic diet. They might have brain stimulation called the vagus nerve stimulator, or they might use cannabinoids such as medicinal marijuana, which is either by prescription or by prescription by a practitioner. This is a list, a busy slide that talked about the usage of drugs. So drugs for seizures have been going on all the way from the 1800s, and it really gives you just a general sense, if you can kind of look at this slide, over the course of years and decades, from the 1800s all the way, over 2000, as the name of all these different drugs. And it's mentioned about first generation, second generation anti-seizure drug, the ASD. It really shows, and I've been practicing since the early 1990s. So for me, what I've seen in my life term, in my practicing neurologist, I've seen a lot of drugs that started coming out when I started practicing. And in the last like 10, 15 years, there's tons of different seizure medication. And that's at the far top of the slide where the scale goes up with all these various names. And there's still new drugs coming out. There's lots of drugs coming out. And the reason why there's so many drugs that come out, because not all the drugs work. They don't always work for everyone, and it's I hate to say it's a big market, but it's a pharmacologic market for the industry, and they make money. They make money, and they're trying to sell their product. So I work with pharmaceutical companies. This slide really is more of a philosophical comment about the drugs that we use and the possible side effects. There was a philosopher back in the day in the 1400s who basically made a comment: all substances are poisons. There's none which is not a poison. The right dose differentiates poison from a remedy. And this is basically the issue of side effects. So any kind of side effect, whether it's over-the-counter medication or prescription medication, if you just take it, or if you take more of it, you can have side effects. So it really is really just a reality to appreciate that side effects are very common, and especially in the developmental population is really problematic in terms of knowing if someone's having a side effect, because some of the side effects might be more related to cognitive side effects. So if you're having someone who's having a cognitive side effect, they can't, how would they, if they have difficulty with their verbal skills or communication skills, and they can't say to you, oh, they're feeling funny or dizzy or lightheaded or confused, their reaction to a side effect might be behavioral manifestation. They might act differently, and their behavioral may be off, and they might be viewed as a primary behavioral problem when in fact it might be a side effect. So it becomes a catch-22 if they're acting out in some way because they're having a side effect, but we think of it as more of a primary behavioral problem. The treatment might be giving them more behavioral medication. So it really can go into like a swamp in terms of really looking at the remedy. This slide talked about what we call an acute seizure action plan. People that have still getting seizures, we need to know what to do about it when it happens. And it's called the first aid of seizure. So this is put out by the Epilepsy Foundation that talks about how to manage a seizure. And it's always safety. Make sure the person's safe, they don't get hurt, they're calm, they're relaxed, they're taken away from any kind of injury, usually placed on the ground if they're not already on the ground, and put them on their side if they don't want to choke, and no one should ever put a finger into the mouth of someone with a seizure. They're going to get bitten off. So don't ever put anything in the mouth of someone that's having a seizure. They always meant, oh, they're going to swallow their tongue. That never happens. No one's swallowing their tongue. They might bite their tongue and have blood, but people are not swallowing their tongue. And then it's the issue about what's called rescue medication. And on the far right, there's that little plunger. There's the person with the thumb on that white device. That's actually one of the what are called rescue medications, and that's a nasal spray remedy. And the one on top of that, there's one called Valtaco and another one called Nasilum. These drugs specifically are in the class of a medication called a benzodiazepine, which is really basically your Valium kind of medication, which is called diazepam, and Nasilum is called midazolam, and these are rescue medications. And the one on the very top is called Diastat, and Diastat is Valium or diazepam given by a rectal suppository, which was the predominant rescue medication for a long time until the Nasilum and Valtaco were out on the market in the recent past. So when you're given rescue medication, it's a question of when should it be given, how is it given, and should you give it at all? And really the rule of thumb is that if the seizure, I usually say if the seizure lasts any more from 2 to 3 minutes and longer, definitely use a rescue medication, but also you can always call 911 because they might need to be taken to the emergency room. But the goal of the rescue and first aid treatment is to keep people out of the emergency room. Unless you all love the ER, I don't love the ER, nor do patients. Care supports is huge. I'm almost done my presentation. Care supports are important. Nursing, direct support professionals. Here we are in our echo talking about this, and we're related to caregiving and the need for caring supports, having relationships, having discussion, understanding the risk, the benefit, the need, understanding about outcomes, adverse reaction, drug reaction, understanding that you'd have behavioral comorbidities that might complicate the issue, coordination between the healthcare provider, and understanding what's the goal of your treatment. Can I really cure someone with epilepsy, or maybe I'm just trying to quote unquote control them? First aid of seizures, the staff needs to appreciate that, the family needs to understand that, and definitely the staff need to really understand what a seizure is, what does it really look like, how do they react, because they come back and talk to me about it and describe it. And data collection, which is what this slide is a calendar. So this is a slide that I use from a seizuretracker.com website, which is the device that I use, which is an online calendar where the family members, the direct support professionals go online, HIPAA compliant, secure site where they're actually putting in like a calendar of the seizure that happened. So instead of them coming in and pulling out papers and pulling out their little paper calendar, this is a calendar they can see digitally, and it records it over time. So it keeps a tracking over time, and it's so easy to use that I make it mandatory in my practice. Seizures in the developmental population can be very difficult because there are syndromes. I mentioned Down syndrome, Dravet syndrome, tuberous sclerosis, Lennox-Gastaut are common syndromes that have a very problematic for having lots of seizures, and there are different seizure types that people may get. I mentioned them in the very beginning, the different seizure types. So you can have individuals that might sometime have one kind of seizure, at another time have another seizure. Most people, it's not the case. Most people only have one seizure kind. I mentioned status, I mentioned clusters. What happens is someone's taking seizure medication a long time, which might be long-term side effects on the kidney, the liver, the bones, the blood, and the issues of health issues and behavioral issues we talked about. And I definitely mentioned about polypharmacy. So not only are individuals sometimes on multiple seizure medications because one may not work, but they also may be on a plethora of other medical medication for their behavior or their blood pressure or thyroid or whatever. And then I also alluded to the issue about side effects and how it might be hard to detect. And then really the issue of side effects and side effect tolerance. Do we deal with the reality? Well, good news, seizures controlled, but bad news, you're unconscious. I mean, I'm being dramatic in my comment to that one, but it's all a matter of putting up with that kind of stuff and not. data collection, and I talked about that and communicating to caregivers. And the issue of transition to care is very near and dear to my heart, because this is kind of what I deal with adults, not children, but it's transitioning from pediatric care to me as an adult neurologist and picking them up, or even the geriatric population going from an adult to an older person and transitioning into kind of care. So I ran through this very quick, and I probably took longer time than I wanted to do, but I guess it wasn't too bad. So I'm now going to take a deep breath. I'm going to drink a little bit of something here, and basically I'm going to stop. I'm going to stop sharing, and I'm going to hand it back to my colleagues. All right.
Thank you. So I'll welcome questions from our attendees, from panelists. I would like to start with a question. What makes a seizure over 5 minutes one of greater concern?
Well, what happens, Cameron, is that when a seizure is lasting more than a minute, 2 minutes, 5 minutes, is basically it happens with the airway. So your airway is closed, you're not swallowing, you're not breathing well, but also the heart. The heart basically, it's stress. It's basically like a stress upon the body. And the stress upon the body builds up stress, and the heart is being compromised, the lung is being compromised. And also what's happening is you're building up in the body the abnormal electrolytes. Your body is stiffening, you're not getting good airway, the kidneys, the liver, the brain, their whole body is getting damaged. And some people who have seizures that are bad enough, you can actually have some brain damage. You can actually have loss of oxygen to the brain. Long-term memory problems can happen when seizures are happening. So that's really what it is that's why they use the word status epilepticus as a unique entity, and we have a protocol. So when people have called 911 or go to the emergency room, we commonly as physicians, we say they're in status. And when they're in status, it puts a whole level of priority on the actionables that we do medically in emergency to tackle it, as compared to someone who had a seizure that was a minute or two, and then you're dealing with it as an aftermath and how to treat it. So status is the ongoing acute treatment of the seizure that can be very horrible.
Thank you. Dr. Bishop, please.
Yes, thank you. Thank you for an excellent presentation and getting into the details that help us think about all of this in terms of health and diagnosis of people for a type of dementia. My question is related to what fascinates me is that early onset, infant, childhood, and then the leveling off or decreasing and totally stopping of seizures, and then after the age of 50, seeing that increase again.
Right.
Do we have any idea of the factors with that prevention? I'm thinking in terms of there's I'm sure a relationship, brain health. Is there something we can learn from all of these patterns that can help us think how we can keep better brain health
Right.
as people age?
Well, it's a perfect, great question, Kathy, because it is related to, like, why is it happening? So why do seizures happen early on, and why do they happen late? And it's all related to what happens in the brain. So, and that's the issue of our, both for developmental disability. Why do people get developmental disabilities in the first place? Why is it really happening? It's a brain dysfunction. So when there's a brain dysfunction, whether it's genetic or exposure, or environmental or toxic, so it's a brain dysfunction. So the issue of prevention for early seizures in infancy is related to maternal fetal health. So, but if it's genetic, like tuberous sclerosis or Dravet, there's nothing you can really do because it's genetic. And Down syndrome, which is genetic also, there's nothing you can really do, but it clearly does go to like fetal alcohol syndrome or things like that, or some kind of other exposure that the mother would have been exposed to some drug or toxin or medication that she was on that would have done that. So definitely early on, and it does go to the issue of wellness and health promotion, maybe differently, of course, for the mom, young mother. But the issue is that why does it happen later? And we certainly know about dementia, Alzheimer's. It's a brain dysfunction, but it's also related to normal aging brain, and also is related to other issues of injury to the brain, concussion. So older people who don't walk as very well, what happened? That they fall and hit their head, or they have a stroke. So definitely the issue related, how do we prevent a stroke? Wellness. How do we prevent falling? Ambulation issues. How do we prevent? So it does go to the reality, Kathy, as you're describing, is wellness and health promotion. So the more we think about those promotive measures, therefore you would think that maybe the risk of those seizures that we are talking about in the demographic would begin to also reduce. I agree with that totally.
Great, thank you.
I was wondering the same, Kathy, so thanks for asking the question. Dr. Ezralou.
Yes, thank you. And again, I ditto. That was a great presentation, Dr. Keller. And
Thank
so I have, sure. I have some questions about what the literature says for neurologists regarding the behavioral issues that may be displayed by individuals. I mean, you indicated a relatively high
Right.
amount or percentage of people who kind of manifest behavioral problems. So do they cluster around any particular behavioral challenges?
Well, I'll
That
give you a
would be
certain
helpful.
example. Well, I'll give you certain examples. So there's one type of behavioral challenge that happens specifically in people that have what's called temporal lobe epilepsy. And temporal lobe is is on the side of the brain, on the right and on the left side. And if that's a focal seizure, that part of the brain specifically is where the short circuit's coming from. And people which have these focal seizures, staring spells, an aura, which is another word I probably didn't really use a lot in my conversation, if they have them and they have them enough over time, it creates certain behavioral and personality changes. So people start developing certain habits and personalities that might be different. And I'm broadening my definition here a little bit, Lucy, about my behavioral manifestation about personality changes. So in my world of treating temporal lobe epilepsy, we have like a categorization, that they have a certain behavioral trait associated with the fact that they've had multiple seizures, and also the problem also with temporal lobe seizures, it's the same area of the amygdala and hippocampus, which controls memory. So
Right.
also people that have recurrent seizures, epilepsy, over time, they get shrinkage of that area in a scar called mesial temporal sclerosis, which is scarring, which you can see on an MRI. So those are the behavioral changes. There are some memory changes that just related to the fact that you can have seizures in a certain kind of area related to that specifically. The other thing that I think is really issue is those that are certain seizures that are manifest by behaviors themselves. They're like a frontal lobe seizure. So in someone that's having the front of the brain having electro short circuit, the manifestation isn't a grand mal seizure. It's not a tonic seizure. It might be they're acting off. And it might be they're acting unusual, they're having an outburst, are they impulsive? And I see that at times from a consultation standpoint, they would say to me, are these behaviors actually seizures? So I'm often asked to see whether or not a behavior that they're having is a form of a seizure. And I try to be open-minded about it, but it's not always so easy to know. So that's why we have testing. So the EEG is so important to do. And EEG, which is, I don't know if anyone's had an EEG or knows them, it's basically all these wires on your head hooked up to a machine, and all that little red squiggly line I was showing you earlier, that's what you see basically, but I showed you two lines exactly. It's a lot on either side of the brain. And what we do is we try to correlate a behavioral change on an EEG and say that if they manifest behavioral change while they're wearing the EEG, we say, aha, that EEG did not show a seizure. That behavioral change is a primary behavioral problem. But the
Gotcha.
thing about it is that EEG is only 20 minutes long. So we have the issue about using what's called prolonged video EEG monitoring. So if the EEG is normal after 20 minutes, and which is most normal routine EEGs, we then order overnight EEG, 24 hours, 48 hours, 72 hours. So we have to know what the hell we're dealing with. And then the other part is related to the complications after the seizure is over, called post-ictal behavior. So after a seizure stops, the electrical short circuit stops, the brain is recovering. When it's recovering, how is that person going to feel? How are they going to act? So after, it's called post-ictal. Post-ictal means an event. The word ictal means an event. Post-ictal means after the seizure. After a seizure, people are confused, disoriented, and that can happen after a lot of seizures. And then I mentioned also about behavioral manifestation of anxiety and even some of the side effects of medication, irritability. You can actually get side effects from medication like levetiracetam or Keppra, and other seizure medication can cause depression, anxiety, irritability. So side effects would also be direct. And I can go on and on with all behavioral issues related to that.
Dr.
Thank you.
Keeler, I wanted to bring a question forward from our Q&A box. And first, a big hello to our friend Ann Hart, who's joining us from Austin, Texas. She asks, has there been any progress made with regards to EEGs for people with IDD? Specifically, she shares that her son has had a seizure disorder for over 20 years, but they've never been able to complete an EEG.
Well, that's a great question, and it's related to compliance. So basically, and I'll just broaden your question. I think it's a really wonderful question about compliance. So when I want to treat someone, I need knowledge, I need information, and that's testing. So having an EEG is part of my test. So if I'm a cardiologist, I would want an EKG, I would measure the heart, and if I'm a neurologist, what do I look at? I look at the brain, imaging the brain. So the compliance would be, can I even image the brain? Can I get an MRI? So getting an MRI in someone with a developmental disability is not easy, and it requires sedation. I would have to do what's called conscious sedation by having an anesthesiologist totally anesthetize a person so they're literally unconscious. And you can do the same thing for an EEG. And the EEG, the one thing difficult, I mentioned conscious sedation for an EEG, is that the sedation itself may actually have an impact upon the finding. So typically, we rather not sedate the person for an EEG. You never generally want to put them on Valium or any kind of medication during the EEG, because that actually can affect the result of the EEG. So often, what's thought about, and this is more theoretical than fact, is the issue of desensitization. I'm sure many of you may or know what desensitization is. It's almost like the same way. How do you get someone in a dental chair with a developmental disability? How do you get them to sit there, open their mouth, and have their teeth worked on? Is desensitization. So there are definitely centers that would basically work with the person in a slow way to get them step by step over time, to not just look at the wires, then then I'm going to touch your head, and then and this is not in the same visits, over time to get them used to it. And that's really what desensitization is, until they're desensitized to the study itself. And that's really what it is. And the other part about it is the kind of equipment. So they have a EEG, and I mentioned wires, because the EEG wire, again, I don't know if anyone's had it, is basically, I could probably show you one here, I don't have it in front of me. It's actually a wire, and the technician scrapes the scalp. They're scraping it like with a marker. They're scraping it to get the skin. So the skin is there. It can't be sticky, it can't be oily. And then what they do is they put it down, and they have glue, as a form of glue. And they put like a cotton swab on it, and then it hooks to the wire, and they do one after another on both sides of the head. So you can imagine, from a tolerability standpoint, who's going to like that? So what they have is it's a cap, and it's basically a rubber cap that you basically just put on the head itself, and the cap already has the wires inside. And that purposely is for people that are sensitive to all the wiring and stickers. And then they have another cap that came out recently, which is basically a strap that goes around the head with wires on it, and you basically just put it on, and it's like has a suction cup. And there's certain devices like that. So the technology has advanced, but it certainly could be a lot better. But it's got to really be done under the right circumstances by the right people, with people that have what's called patience. Yeah, you probably know what that means. Patience. Do everyone have patience? I don't know if I have the right patience. It takes time and patience and dedication to be able to do it.
Wow, a wealth of information. Thank you to everyone for your great questions. A+ for paying attention and having good questions. So I would like to transition to the latter half of our meeting, which is to have a case presentation by Dr. Bishop. As a reminder, she'll present to us the anonymized details of this case. We're seeing that it'll be Diana. And after she presents these details, we'll open it up both to hub team experts and attendees to ask any questions of clarification, and then move into sharing suggestions and advice that Dr. Bishop can take back to Diana, her caregivers, and team. So thank you, Kathy.
Not a problem, though it'll be a little bit different today because
Great.
this is actually a case study from 1997. I've been undergoing a lot of health tests, a lot of health stresses the past week and a half, and I'm on orders to not be doing a lot of heavy lifting. So I have been going through piles and piles of old papers and came across this study from 1997. And it really made me think that all of us and everyone on this call is essentially already an expert on this topic. And you are the people that need to help lead the healthcare providers in partnership together to figure out how you conduct a complete and appropriate differential diagnosis, and also make sure that the more recent information is known by the healthcare provider, because it probably isn't. In this case, reminded me of how far we've come, and thought it would be great to share. This really is one for us all to be critical thinkers and think what we can do to help change the system, help to add information to the system. So it's unusual today because it's not looking for any solutions because the person is no longer even available to us from this long ago. But it really is thinking about what's changed and how we can do things differently. But I also want you to think that many of our healthcare providers who provide healthcare, in this case, we're talking about a woman with Down syndrome, have been taught back in the 80s and 90s, may not have any of the updated information, and may still be thinking in terms of the 80s and 90s in terms of a diagnosis. And so again, we have to be the advocates, we have to be the experts to work in partnership to figure out together what best to do. And this was actually one, I was at the University of Rochester School of Medicine and Dentistry at the time. We had a 3-year state-funded geriatric assessment clinic where 88 people came to us who either had a diagnosis of a type of dementia or one was pending, it was being questioned. And Diana was one of those 88 people. I will tell you at the beginning, out of the 88 people that came to us, there were 8 people who left us with the diagnosis of a type of dementia. 80 people were found to have other underlying causes. Diana was one of the 80 people who left us without the diagnosis of Alzheimer's disease. Now, remember, in 1997, it was assumed that life expectancy and being old, certainly for a person with Down syndrome, we were even in those days talking about 30s and 40s of the onset of Alzheimer's disease and other types of dementia. So Diana was considered an old woman at that point in terms of Down syndrome and life expectancy. She was living in a residential setting and attending a sheltered workshop. Very social, likes group activities, was liked very productive in terms of terminology that was used in sheltered workshops at that time. She had a history of sleep disturbances, waking up at night, frequently complaining of pain or hunger. She had recently had a sister who had been her primary advocate, moved to California. Remember, at that time, we're talking letters and phone calls as a way to remain. She had lived near Diana up until that time, and so this is a major change in Diana's life as well. Well-liked long-term caregivers who knew her very well, which is unusual. And really upset at some of the changes they were seeing and wanted to find out what was causing the changes. And that's where it always starts, with the caregivers, be they family caregivers, organizational caregivers, family and organization together, starting the process of determining what is going on, what can we do to make a difference. This is why, again, you're the experts. You know that it's not 100% of everyone with Down syndrome. And so you know to help guide the healthcare provider with information you provide to help them look at other possible underlying causes. She was referred because of a decline in social interaction, participation in group activities. Again, a decline as much as we knew from what was reported. I was part of the geriatric assessment multidisciplinary team, just to let you know that there had been a change from what we knew as baseline in terms of her participation. She was refusing at times, not every day, but refusing to go to the sheltered workshop, which she had seemed to previously enjoy. She had a reported memory loss, but we could not get specifics on what those memory losses were. There was not a good baseline available. That was not in the days when anyone had thought about Dr. Ezralou's EDSD and documenting changes to use that for information. So, and that's not many years ago, and many of us on the call, that is within our career lifetime, that this was, in fact, when many of us started with this disease or were in the middle of understanding this disease, this was the state of the art. And by the way, having the time and having a multidisciplinary team to this moment in time is extremely rare. And so we were providing state of the art. And yet, as I looked at it today, went through the notes, I realized how much we missed because we just didn't know, and things we could have done differently. She was complaining of pain and discomfort. You can imagine that a lot of that refusal to go to sheltered workshop and complaining of pain and discomfort, just like seizures can be, Seth, often are decided, especially after one test hasn't found anything, that it's a behavior. It must be a behavior. There's something causing this behavior. She was generally reported as different than she had been historically. So conditions, she was seen by a primary before she was referred to the geriatric assessment clinic. The general examination, blood work, vital signs, thyroid ruled out, some testing, diabetes, hearing, visual impairment, respiratory. After finding that they couldn't find any, I shouldn't say changes, that couldn't find any underlying causes that they would think were attributable. Probably one of the problems was that they were looking for a cause. And we know in the general population, and this still is not commonly thought about today, that it is always multiple causes in an older person, and even more so likely in an older person with Down syndrome or any other form of developmental disability. There will be probably some lifelong challenges and complications, conditions that have impacted what is being seen today. So she was referred to the geriatric assessment clinic because after a very preliminary ruling out, a kind of a very short and brief differential diagnosis by the primary, referred because it was assumed she was 43 years old, a woman with Down syndrome. She must have Alzheimer's disease. And so she was referred to the geriatric clinic, which was fairly new at that time, and unfortunately only a 3-year duration. She was seen by a multidisciplinary team, approximately actually 20 hours of office time. Seth, I would assume that would be considered a lot of time in comparison to what usually happens in healthcare providers. Am I accurate on that?
20 minutes?
20 hours.
I'm sorry, 20 hours. Oh, absolutely. God, yeah. Oh my gosh, yes. Oh yeah.
Yeah, it was at least 20 hours, and
Wow,
it was
yeah.
by multiple people on site in the residence. I mean, it was a very extensive differential diagnosis. It was
But that's not
considered
20 hours straight. That's off and on.
No, that's accumulated
Can
over
you
the
imagine
time.
having, I thought 20 hours, let me go to sleep.
No. No, the initial with the physician was a 2-hour.
Oh, okay.
But there was time out and breaks and I mean, there was a 2-hour time initially to
Right, wow.
determine who on the multidisciplinary team should be the next to come in and meet Diana and to determine some follow-up. So body scan for osteoporosis was ordered for pain management, and found, and then pain management considered, and things like D3, being prescribed. Sleep apnea had been thought about. There had not been during this time any extensive testing, recommendations for follow-up for that after. But there was even more concern by the team as a whole, to look at the sleep environment, how it's being set up, and not to jump to sleep apnea, and especially to look at the complaints of pain and hunger at night, and to consider that in the whole context, as well as to consider the whole social context of not having the contact with the sister had before. So all of that was considered in this assessment clinic. Seth, I assume you would also agree that this is not, even to this day, normal practice.
No. Yeah, I mean, what I'm interested, I know you're going to compare and contrast, like what was then and this is now. Well, I mean, do you mind if I make a comment?
Please do. In fact, I'm
I'm
hoping
just
others
curious. I mean,
will as well.
Well, what I'm curious about in the assumption of Alzheimer's, there's no like study, like imaging of the head. They did all these other stuff, but then they want to look inside the head, like an EEG or a scan, a CAT scan. That's not considered an assessment part.
Not in 1997.
Wow,
Not at that point.
I'm surprised.
It isn't today, Seth. I may be, and Lucy, you may want to comment that I'm finding frequently that that's not before the diagnosis is made.
Right. All right. So, and I had a question about, just kind of checking in about her psychological
Absolutely.
and emotional state. I mean,
Absolutely.
pain, she had osteoarthritis, so the medical management of pain, but also what impact did it have on her quality of life, on her mood,
Absolutely.
on her willingness to participate in the show. Maybe sometimes she woke up and was in particular pain, and that interfered with her motivation to go to day program. So, just kind of general changes in terms of physical, sensory, but also the impact upon how she was emotionally and her quality of life.
And there was a psychiatrist on team, and she was referred to the side. Every single team member was part of every single one of the 88 people who were referred. So that whole comprehensive, I've kind of summarized this down and didn't get into that. That's why that was considered state of the art then. I will say that that particular clinic still continues on today, but has had major challenges because of COVID and the changes and challenges are in healthcare system right now. But this is not even the state of the art across the country for healthcare for people with IDD, and that's why I wanted to present this today.
That's true. And it's an exemplar. It would be nice to think that we gather information about somebody through multiple disciplinary perspective, but you're absolutely right. That is not the.
And that's what I want everyone on this ECHO call today to think about that and understand at what point you're dealing with healthcare providers, where they are in their knowledge, and to understand and give yourself credit that you have become the experts by your interest, your experience, and the changes in the system to make sure that people, not just with Down syndrome, with any IDD, are receiving closer to the state of the art, or at least receiving a thorough differential diagnosis when they're referred. So there was also an OT on staff. I was the gerontologist. We worked closely together on daily functioning, interviews with staff, observations and videoing, sensory issues and challenge. We did a lot of that together. I would really work, she would work on the objects in the environment. I would work on modifications and setting up a healthy environment for functioning. Go ahead, Luce.
Yeah, so another thing you said, which I really wanted to circle back to, because I think
Please.
that's something that I have found, is that many people are stuck in the last century in terms of their conceptualization and understanding of what might be going on for the individual. I mean, I see that, in terms of behavioral formulations and how to intervene, and psychologically, where there is a little bit of a therapeutic disdain about offering some psychotherapeutic options or psychosocial options to people with intellectual and developmental disability. So I really appreciate you kind of, lifting up this issue about, okay, where have we gone since the last century? Where are we now in terms of how we might differently approach all this?
And that's why I was so excited to be able to do this today. And that's why I've taken it quite a bit away from the concept of case study, one that's present at the moment. But I hope you'll all feel it's worth your time. And I hope participants will also, please feel free, raise your hand and make comments. And you may have experiences back to 1997. This is bringing back to you to think about the challenges you have. And I really want you to be able to place yourself back there and know that most of the country is still back there in 1997. So the environmental modification, sensory issues, nutritionist, dietary review. And Cameron, I assume if there's someone has a question, you'll just let me know. So some of the recommendations, and this isn't all extensive, and remember, I'm going back to 1997 with my brief notes that I still had now. Sleep
Kathy,
apnea
I
follow,
wanted
please.
to, we just had a question that is pertinent to your last comment and discussion,
Perfect.
which is, are you seeing any, and this is a collective view, are any of us seeing improvements in medical schools in regards to this area?
Maybe 3 or 4 in the country, would you guess? And you pockets, Cameron, you can talk about the dental school, for example, improvements. Seth, your concepts on that.
Yeah, I mean, honestly, it sucks. I mean, it really is terrible. I really think the problem is that whatever you might learn or they might learn in medical school, what happens when you get out to the real world of practice, I think that's part of that. So you can get a lot of education, but when you're actually put into an untenable practice situation where you can't practice what you learn about, I guess, because they practice what you preach. But if you're put in like a rush job, so you can imagine, you're talking about a 20-hour assessment for geriatric, but in most situations, again, geriatric assessment versus your general normal practice, well, that's what most people get. And what is the general most practice? You're basically, if you're a primary care provider, you're basically going in to see a doctor for a few minutes. You're seeing them for a few minutes. If it's an annual wellness visit, which is really what's supposed to happen, then you're given more time. But are you able to really give them, that amount of time? And I think the problem is because it's often multifactorial. And you were kind of saying that, Kathy, about the problem that a lot of people have. It may not be just the dementia, it might be their hearing, their pain, their sleep, their behavior. And it requires a lot of things that you really need to do to kind of put it together. So I think the system of how we care for people is really bad. And I think that's really where a lot of the problem is. Yes, you need to learn how to do this in school. And I think people are getting some degrees of education, but you're basically our system of care in the United States, and I can't speak for, all around the world, we just don't have a great system of how we care for people with these complex issues.
Catherine, this is from you.
I'm sorry.
This is Bonnie. I know that we have heard that there are a lot of not a lot, but family practices are really getting to be reluctant to take older adults, especially with lots of complexity, because they take up too much time.
Right.
And so I think that, like you're saying, it's one thing to learn about it, it's another to do it. And then it's also another, once they are in a family practice, excuse me, that they're reluctant and they don't have geriatricians to refer them to. Sorry.
Yeah, exactly, Vonette.
We don't have a good care, and the other problem is you're not getting paid. So it's not only don't you have enough time, but you're not paid for the time you spend. So for me, in my practice, basically, I have to code. So I provide an office code on the complexity of the visit, how long I spent with the patient, and you have to have these qualifiers. So when I'm trying to get a higher rate for my time really put into that, often I'm not getting it. And so you're getting screwed by the insurance companies by trying to take care of complex patients. And as you're saying, Vonette, it's basically it's a downer. So why should practices start doing this when we're not getting paid? It's hard. So again, it goes back to the system. But I think the one saving grace, and I don't know if this will be the case, is the guide model. So as we in the NTG know, because we're going to be part of this, it's this program that CMS, Centers of Medicare and Medicaid Services, putting together to appreciate that these are complex individuals that need more time, navigation, discussion, training, connection to communities and families, whatever. It requires that. So there's this new program, and we in the NTG and my NTG colleagues certainly know about this. We'll be talking more about it. This is something that we know that you can get paid better, more time, you can put together the systems better. And so this is the beginning of a process in the United States that's starting this year and will be looked at for the next 8 years or so of how to create a better system of care. In my own personal work here in New Jersey, and we all deal with older people. I mean, who doesn't, what medical practice doesn't see older people, which is getting more prevalent. So even in our virtual healthcare system, which is what I'm part of, they're actually putting together a geriatric care line. And they're basically now, and this is like now, they're putting together all these things that we hope this to be, because we recognize it as an untenable current situation. It's just the status quo just isn't good.
Yeah, let me just say something before, I know Catherine and Lucy are waiting. The most important follow-up here I want to point out, and I'll go on to the next slide, but then take the questions. I want to make sure we have at least 10 minutes that I can talk about some of the changes. But the most important, she was determined not to have Alzheimer's disease. That's the most important conclusion. And she left without that diagnosis and all other of the multi approaches to modifications, to dealing with underlying issues that were causing the decline. And so that's really essential for us to keep in mind as we, after the questions, move into the next phase of what has changed. So please, Catherine, don't mean to keep you.
You're on mute.
You're muted.
We saw you mute and unmute, but we still don't hear you through your microphone.
Why don't we take Lucy's while Catherine corrects it?
Yeah, so I appreciate, I wanted to get back to Seth, what you said about the system needing to be changed. I agree with it. The other thing I want to just kind of shine a spotlight on is this idea of complexity versus simplicity. And, I think in my experience, there's been a rush to judgment about dementia, and not as Dr. Bishop would say, not an attention on differential diagnosis or just kind of parsing out what might be going on for the individual. And sometimes that comes from providers and families, where there is the real push to have the answer to something without really necessarily realizing the complexity that's involved in arriving at a reasonable conclusion about this. I mean, there's so many other things that may be going on with an individual, even if it turns out that the person does have a diagnosis of dementia, Alzheimer's disease, or other type of dementia, there still may be ways to intervene, and taking the time to just kind of parse that out helps the team understand where there might be productive avenues for intervention.
Catherine, have your sound.
No, can't hear you.
Okay, then when you get it, just let us know. I'll go on with this because I want to make sure we get to this part. This is what struck me as I was reviewing these notes a couple of days ago. What do we know now we didn't know then? And are medical schools teaching the information today? Most likely not. I always say that if they get a 3-hour lecture on Down syndrome and the higher risk for Alzheimer's disease, that's likely the lecture they get on IDD in medical schools, unless I'm wrong. This isn't all of them, but more that it is true than not. So life expectancy, I'm focusing on women because I'm really going to be going into menopause and estrogen, which is why I wanted, and that was, Diana was a woman. Life expectancy for women with Down syndrome has increased to an average of 60 years of age. We know the current longitudinal studies indicate 56% of adults with Down syndrome, both genders, do not exhibit the significant losses attributed to Alzheimer's disease until 60 plus, may not. The studies are still going on. Autopsies are demonstrating that there's the pathology seen after death in the brain that but did not show the significant symptoms during their lifetime. These are studies still going on to this day. And there is a similar study in the general population on nuns that show that a high percentage of nuns who were very mentally and physically active and continue to stay engaged in life were found not to show the symptoms of Alzheimer's disease, the significant losses during their lifetime, but upon autopsy after death, the pathology was present in the brain, but they were not showing the losses, the significant functioning and cognitive losses that would be expected attributed to Alzheimer's disease. That is significant. There continues to still be aging myths that everyone who's older will have a form of dementia and that significant cognitive and functioning decline is normal. The myth is even stronger in people with Down syndrome. In 1997, that's why we wrote the grant and had the geriatric assessment clinic, because we knew that there were many underlying causes and wanted to make sure that a differential diagnosis was being conducted, but we were still doing it without information that even started to be available then. Today, we're looking at differential diagnosis is even more important than ever. It's still not being funded for appropriately or substantially. And there are all kinds of new drugs and treatments that Seth could do hours and hours on that. Until recently, persons with Down syndrome or ID have not been included in the clinical trials. Should I go on to the next slide? Or do you want me to take some questions, Cameron?
No questions currently.
Okay, I just didn't. This is really significant, and this is where I realized that I know our team made a major oversight. We should have been thinking about Diana as a woman who was in probably menopause stage. I know I have been in the disabilities field all my life. I have never had a class, no matter at what level, whether it was master's, PhD, or bachelor's degree, that talked about anything other than women with Down syndrome, did not show the cycles. In fact, that I was taught very early on that women with Down syndrome did not have menses and did not go through the cycles. We know so much more today. We know from studies that 87% of women with Down syndrome and 69% of women with ID had stopped menstruating, which means they started by the age of 46. That's really significant. Diana was 43, and yet we never thought about comparing her. And we often say to at least about 20 years, we think of the person in terms of being older. So Diana at 43, we'd be thinking at least about 63, but no one ever thought about menopause on top of everything else. All women with Down syndrome in the studies, and there are thousands and thousands of women with Down syndrome that participate in these studies, stopped menstruating by the age of 51, and all of the women with ID by age 54. The estimate median age for women with Down syndrome was 47. You can see that's significantly younger than the general population. And there were women that the median age for women with ID was 49.3, still significantly earlier. We know a lot about these days that women Young girls even can have estrogen deficiency. It's a lifetime deficiency. Why this is so important is these were studies coming out in the late 1990s, early 2000s. We knew this information, but the IDD field was far behind hormonal replacement, the need for estrogen, the impact on estrogen, unfortunately caught up about the same time that the general population, the studies were discontinued. And I'll talk about that in a minute because of the risk of hormonal replacement therapy as it was then. There are initial Australian and Swedish small studies on women with Down syndrome found they had a shorter life expectancy than the men that were in these studies. I remember being in 1999 at the World Health Organization, where we were international group researchers and educators who were there to talk about conditions of care and how we can make a difference for people with IDD. I led up the women's group, and I presented the findings by the Swedes and Australians. This is back in late 1990s. It was received as extremely controversial and should be overlooked as not significant because it was a small study. And my group and I's position was that it may be just an outlier, but it's an important enough finding that we should be really asking what's going on, because we may be able to learn for general population for women as well as to this whole impact of what estrogen does, the impact of this much earlier onset of the deficiency. This is in August 14th, 2022. Catches up. I'm sorry, that should be 2002. Sorry. In 2002, there were two major studies of tens of thousands of women who were on one day it was announced that they were ceasing the studies. They were stopping the hormone replacement studies and the clinical trials. And it impacted, and this just one study that was announced on that day, 16,608 women who literally on that day were told, go back and see your doctors. You're no longer participating in this study because it's too dangerous. They were finding invasive breast cancer, ovarian cancer, uterine cancer, which was attributed, and that had been known for 20 years before these studies, but kind of discounted as maybe they're not as relevant. I'm not bringing this up to say the controversy of this. I'm bringing it up to help you understand. By this point in 2002, the IDD field was starting to catch up and was starting to give everybody estrogen. But then now here in the middle of the debate, and no one thinking that maybe each and every woman, especially women with Down syndrome, should be considered differently, not en masse in terms of this study, because they start out in their late teens or maybe early teens with this estrogen deficiency that impacts their lifelong functioning. And so that's why this study is extremely important. The earlier onset of menopause in women with Down syndrome has implications for their health because menopause is a risk factor in the general community of women as well. Risk factor for heart disease, depression, osteoporosis, breast cancer, and dementia, also thyroid deficiency. And again, because there is the much earlier onset and then the impact of the lifelong estrogen deficiency, that means that these risks are likely higher and should be very carefully considered as part of menopause. And this estrogen is one of the central areas that should be studied and ruled out and looked at very closely today. We still have not caught up to this in the healthcare community. This is the same thing, reach menopause younger than 45 years. Those with Down syndrome, younger than 45 years, greater chance of developing dementia. I will question this, is a greater chance of developing dementia, or is there a greater chance of significant losses in function and cognitive capacity that may or may not be totally, and probably is not totally attributed to a type of dementia or to Alzheimer's disease. And so with this, it's a greater chance, but are there appropriate differential diagnoses being conducted for these women? And are these women, are they part of making sure that all of this is being considered, this more recent information. I'm going to end with my last slide. I'm hoping there'll be lots of comments and discussion. The last time I had the kind of pain I've been going through for the past couple of weeks and trying to figure out underlying cause was when I was preparing and 2 weeks out for defending my dissertation for my PhD. That turned out to be a kidney stone that I couldn't pass. And after I defended my dissertation, had a lithotripsy. So as I was thinking about this and implications, I remembered, and I started my my defense by saying, I take sympathy, I take whatever it takes. I'm in pain, but I'm here because this is so important. And then they did the usual. They let you sit outside for 45 minutes while they all deliberate, knowing full well that they've passed you. I mean, my advisor said, I would never let you get there if you weren't ready. But I sat under a portrait, a beautiful portrait of Dr. Burton Blatt. And Dr. Burton Blatt was affiliated with Syracuse University, is one of the mainstreamers, one of the major rights proponents for people with IDD, at that time mental retardation. And sitting there for 45 minutes, I had a lot of time to deliberate this quote, and it was a great time well spent. What we know today and do now, we will regret tomorrow. So while we may think we're there with healthcare, that we know what we're doing, I think it's important that we took this step back today. Think about how many people are still back there, haven't even been led along to where we are today. And then, of course, the impact of COVID and what it has done. So open it up to questions. Oops, let me go back.
Yeah, thank you, Kathy. I mean, I definitely feel that what we are doing now, at least now, will be very different tomorrow. I mean, yes, compared to, all those years ago, Kathy, I mean, there's no truth, but I think we're in a turning phase of how we're going to be looking at this whole situation in the next 5, 10, 20 years based on technology and research.
Yeah. Let me say, though, I don't think I made a good point. People with Down syndrome, including many women with Down syndrome, are not participating in clinical trials. And so while we're moving ahead in our knowledge and so much and new therapies, as you know, we've had these discussions on and on that are available, they're not available and with the same informed information as we do for women in the general population. It hasn't caught up, and COVID has made it even worse. So that's why I thought, yes, we're hopefully in a change, but we're the change makers. And I wanted to make that point today really strongly.
Lucy, let's hear your comments and questions.
Yeah, thank you so much. This was a very thought-provoking, kind of retrospective as well as kind of prospective way of thinking about things. I was curious about those 88 individuals, only 8 of whom exited from the clinic with a diagnosis of Alzheimer's disease. And I wondered if there had been any longitudinal follow-up studies regarding, which,
one of the
was
fallacies, as you know, yeah. The only person, Lucy, I don't know if you remember the slide that we have in the beginning in the 3-day of, I'm losing his sorry, having a real, Albert, sorry, it's not D, Albert, that we talk about. And that's only because of doing the work that we've done with the NTG. I connected back with the nurse to Albert to find out updates from him from the 1990s. It was a typical 3-year grant. We had extensive research studies and data we collected, but the team didn't even stay together after the grant was over. We did develop people within what was the DDSO there, and they continue on today. And they were people we trained, and then they train others, and that's been going on. But we've had no capacity to be able to follow up, and it should be.
That right, and maybe that's a lesson for us in future funding that we might seek, that we also want to find out, so what's the follow-up? What's the outcome after, whatever is kind of generated in the initial stages of this? But very good work, and thank you for sharing that. Yeah.
Thank you.
I wondered, Lucy, I'm prompted to just start talking out loud, which is there are longitudinal studies funded by the NIH and others for decades. Though, to your point, it takes a dedicated principal investigator to renew that funding and have a succession plan to pass on to others.
Right.
I wondered if an alternative route is to get permission to look at Seth Keller's patient records over the decades. What I'm meaning is, you can have retrospective chart review for data if you have HIPAA protections and on and on and on. I'm wondering if that can be a secondary option for people who want to look into this.
That's an interesting, thing. Seth?
Looking at my record for decades, is that what you're saying? I kind of what? Oh yeah,
Well,
that's what you want. You're right.
Well,
Yeah, you can
and it
have.
needs
Yeah,
to
sure.
be, so what I'm proposing is, are there clinicians like our renowned Dr. Seth Keller that use best practices in their clinical practice and therefore could be considered a gold standard of clinical practice in caring for adults with IDD as they age, and of course then look retrospectively at certain variables of their data to see how, almost in a sense, in the wild, these individuals have progressed over presumably decades.
I mean, honestly, with the way I look at it in terms of so-called what I'm doing, it's a matter of just being sensitive and caring and listening to people. I'm not curing the world. I mean, I'm not. I mean, what am I curing anybody? I mean, to me, I'm being open-minded as we're all talking about not jumping to conclusions, not making broad assumptions, knowing that it's a difficult, challenging situation about being accurate about what's going on. But it's multifactorial. I mean, I really think that's the reality of that we're all facing. These are complex issues. And yes, they might have Alzheimer's, but they also can't hear well. They also have sleep apnea and they're also in pain and they're also worried. They're also, and their families are worried. Isn't that a common theme? I think that's a common theme that a lot of people are going through in their families and care supports, and they need a holistic approach to be able to care for all that as they're going through what they're going through. And that delivery of care is done by who? Who is really delivering all those levels of care? And for me, as my singular entity, as a one-person workshop in my own life here, I'm only able to do a small part of it. And the reality is that these individuals like this, who are complicated indeed, like a lot of people, they need a holistic approach. So I think that's really where the reality that people are ultimately, no matter if it's 1997 or 2024 or 2050, I don't know how it's really going to change that much, honestly, unless we can cure people. The only difference I think that's going to happen in some futuristic time is that people that with Down syndrome in their 20s or 30s can get some kind of remedy right then that'll start in their 20s, 30s, so that the beta amyloid will never even happen. I mean, I think that's the only way that ever will change in a dramatic way.
Dr. Esverlu.
Yeah, so the other thing that occurred to me that I would like to kind of drop the gauntlet to everybody, including the people, participants on the call, is perhaps what we could use is a format of a case book in which we look at various scenarios and gather various scenarios and looking at teasing out the various considerations and differential diagnosis. I mean, I think that could be very valuable to practitioners, and I think that could be very valuable to providers in terms of just understanding the complexity and putting that out there, like not only clinically what you see, but what do you observe kind of in the person's real world situation, and some thoughts about that. So I'm just dropping the gauntlet, for that, because I think that would be a very valuable project to consider.
I think that's an excellent suggestion, and one we ought to think about. I think that's why I was excited to do this today, because to think about driving us, what can we do next? And it's even part of the echo that we could be thinking of, that we're gathering together at least what we're finding in the echo. I think that's excellent, Lucy.
Well, I want to thank everyone as we approach the stroke of